Riccardo Haupt is a pediatric oncologist, as you see here, from Italy, also a founding member of PanCare, and Desiree Grabow is from the German Childhood Cancer Registry and is the deputy head there, and they will give us an update or an overview over the Survivorship Passport. Riccardo and Desiree, please.
Thank you very much, Catherine, Maria, and Anne for setting up this very nice course and for inviting me to present. I will present today about the passport, and Desiree will present tomorrow about the future development of the passport. Next slide, please. So this, we can skip this one because Lars has already go ahead. And also go ahead, Lars has already mentioned this, go ahead. So what we know is now that what I want to say is that several survivors are not children anymore, so they are between 25 and 29 years old. So the transition from pediatric to adult care is a critical point that we needed to address. Go ahead. And we know already that there are several problems, as Lars has mentioned. Go ahead. So this is a slide which I have stolen from CCI. So this is a survey among CCI members. It shows clearly that all child cancer survivors in Europe, they have extremely variable experiences, both within but also between countries. There is no information about possible health effects and not enough knowledge about screening, what, when, and why they are necessary. Next one. So I think you went back. Okay, next one. Okay, so the other point is mentioning about the transition. They do not feel that general practitioners might understand exactly what the issues of long-term follow-up, and sometimes they do not, they feel lost in follow-up, and they don't know where to go. Next one. And this is a statement made in 2016 by the CCI group, international group. It is a so-called Declaration of Dublin. Next one, in which there are two statements that I want to show. First is the state that we ask for adequate long-term follow-up clinics to be established, where survivors can have access to personalized follow-up care. Next one, and the other statement is we request full disclosure and sharing of our medical history and potential risk to our current and future health. Next one. So this is why, these are the basis for why we developed the so-called Survivorship Passport. Survivorship Passport was intended and is a document to be given to the individual patient after elective end of therapies, paper and electronically based, written in a simple way as much as possible, containing cancer history and therapy information, and providing advice and guidance on patient-specific long-term follow-up for possible late effects, and can be translated in several languages of the EU. Next one. So the general schema in the SurPass is to have a treatment summary in which you have demographic data of the survivor, description of the tumor, and details of different aspects of the frontline treatment he or she has received, with information on possible relevant clinical events. Next one. Then, based on the treatment and the recommendations, we can build a care plan which will, in a semi-automatic way, suggest to the physicians what are the recommended follow-up. Next one. Excuse me. And I will show you shortly a follow-up form which is still under development, so it's not available yet. In case of relapse, of course, you need to have the extra treatment, so you will somehow the passport will be kept on hold. You will people will receive further chemo, so you will have your level of risk might change. You will have new recommendations and so on. Next one. And in case of second tumor, it is needed to update also the tumor description part. Next one. So the story of the passport started, as mentioned by Rod, in the early 2011 with the first European project. It was a joint venture by the ENCA project and PanCare SurPass. In the ENCA, we developed the platform, and in PanCare SurPass, we started developing the recommendations. So what I will present today is the status as today in 2021-22 is a version 1.2, which includes all the PanCare follow-up recommendations that have been described by Leontine and Rod. Next one, and Desiree tomorrow will speak about the future development in SurPass version 2.0 in PanCare SurPass. Next one. So the general outline of the printed document is this one, treatment summary and recommendation, and I will drive you a little bit through this one. Next one. So the treatment summary, we used as much as possible vocabularies which use international codings. So that was for the tumor descriptions, using as much as possible ICD-3 and then ICCC. For predisposing syndromes, we use ARPANET and or ICD-10. For chemo ITC codes, radiotherapy, I will show you later on. Next one, just for reason of time. Just to remember that cancer coding system, the main one, as you all know, is International Classification of Disease for Oncology, the ICD-3, which is mostly used in academia and in registries. Next one. We as a pediatric community, we developed our international classification of childhood cancer, 3rd edition, which will go into a little bit into detail. Next one. And then in administrative levels, usually it is coded with ICD-10. Next one. If you have ICDO information, you can translate the information in ICC-3 and or in ICD-10. Next one. If you have ICC-3, you can do ICD-10, but you can't go back into ICDO. Next one. And if you have ICD-10, you can't do, you are stuck somehow. So next one. So in general, what we know is that when we talk to a patient, to a survivor, people knows, we usually use the international classification of childhood cancer. So we say you have a Hodgkin lymphoma, we have the Burkitt lymphoma, and so on. Next one. So we believed that we do not need to have all the details of, for example, what type of Hodgkin lymphoma somebody else. Next one. So we think that we will keep the information of an ICD-3, but the printed version will say you have an Hodgkin lymphoma with some details. Next one. Yeah, of course, if you have Burkitt lymphoma, you have the same coding. Next one. And the same is for, of course, you can't say you had a miscellaneous or lymphoreticular neoplasm. In that case, the passport will provide the exact detail of the tumor type the survivor was affected. Next one. So the same is for the other. So this is just to show the work which is behind it. I think you can skip this one. Go ahead, Anna. So there is a lot of work to decide what type of tumor type to be printed into the passport documentation. Next one. So the system, this is a screenshot of the system. So when you start typing the information, next one, you will say if it is a neoplasm, benign or malignant. Next one, then you can start typing, and the system automatically provides you, when you start saying HO, you can select quickly what is the tumor type you want to say. You see, and as you see here, we are using the ICD-3 coding. Next one. And then automatically the system, because of the let's say sort of algorithms we built behind from the ICD-3, they will provide also the ICC-3 classification. So after you have provided the ICD-3, you will have both the ICC-3 and in case the ICD-10 classification. For chemo, we use the, as I said before, ATC codes. Next one. And for we have, as you know, all the same pharmaceutical component may have different names. So we have all the synonyms, commercial names are listed into the system. So you can either write Cytoxan or Endoxan or cyclophosphamide, but the system understands that is the same drug you're talking about. And in case survivors was treated with new drugs, there is this other section which will then added as soon as the ATC code will be given. Next one. So for radiotherapy, we did develop there is no coding system internationally approved. So we use the three-tier coding systems for the areas of the body receiving radiotherapy. So you see from the center of this schema, you have a brain, head, and neck. Next one. So just to make an example, you say the large area, the first tier defines the large area which is irradiated. Example, the chest. The next one, the second tier, you can say was mediastinum. And the third level, you can say which was upper or lower mediastinum. Next one, you have also information in case the radiotherapy was given to some what we call the spatial sites like total body radiation, mother radiation, and so on. So this information is already, so you can register at the first level this level of information, and the system knows already that total body radiations means that all the large areas of the body have been irradiated. If the mantle, they know that is the chest plus the axilla and so on. Go ahead. This is important because you need to have this information to be provided to your healthcare provider. Of course, the system allows to have a multiple choice, define if there was a boost on a specific area. You can say which, if it was irradiated the right or the left flank, for example, and there is space for exact details. Next one. Why we used this coding system? Because the coding is important, because as I will show you later on, the algorithms which link the risk factor of having, in this case, chest irradiation needs to be linked to this coding system. Next one. So this is the system that does it show on the web, and then you can include all the documentation about the doses of radiotherapy and so on. Go ahead. And then, of course, as you know, we now speak about chest irradiation, increase the risk of breast cancer, for example. But we know that there are, as shown in this schema, when you give irradiation, you may also calculate what is the exact dose given to a specific organ, like in this case, the liver and the tumor. But that is for future. In the future, we will know exactly the risk of radiotherapy risk for a specific organ, which is not the case today. But so we can store these medical images in the passport for future references that might be useful in the future, not for today. Next one. So for surgery, okay, we have a free text mostly, and then there is a drop-down menu to identify surgeries, as in the radiotherapy case, which activate algorithms. And these are some example surgeries which activate the algorithms. Next one. So the care plan are based, as I said, on this treatment summary and the recommendations, which have been developed by the IGG and the PanCare Followup. Go ahead. So this has been already several times mentioned in the paper, the paper by Rebecca, which are merged all the recommendations available as of today. Next one. So these are all the recommendations, 41 recommendations listed in Rebecca's paper. In red, you have those which are developed by evidence-based by HHG, and in blue, those are consensus-based. Next one. So you see this graph are the most important ones. So are recommendations in which a surveillance test is recommended. Next one. And the other one are recommendations in which are mostly is awareness given to the survivor by the healthcare provider. Next one. Besides all these recommendations, we designed 47 algorithms which link the treatment exposure to the proposed care plan in the SurPass platform, which is now available. Next one. So just to make an example for an algorithm, so for overweight, you can see the risk factors, who is at risk are those three categories, depending on radiotherapy or having a type of tumor or type of surgeries. And that is the algorithm, as you see, is linked to the coding we have been used during the treatment summary preparation into the system. Of course, the coding will not be used by the data manager and data monitor who will upload the information. The data monitor will say radiotherapy to the pituitary, and the systems has already all the coded and the vocabularies into its system. Next one. So this is the general recommendation. In column G, you have the recommendation, let's say, in Rebecca paper. In column H and I, you have the care plan presentation as it is now used in the PanCare follow-up project. And here in column K and the L, in K in particular, you see, because we are the only one in PanCare follow-up using the electronic format of the passport, this is the recommendation, the printed recommendation which come up into the PanCare follow-up project in the passport delivered under the PanCare follow-up project, which is a summary, or more or less not more or less, is a summary in other wording of column H and I. Of course, this is already available in English and for possible other translations. Next one. The printing, so the system will just suggest the recommendation to the healthcare provider. And then you see here there are some blue checks. So the healthcare providers can decide either to accept, to not accept, or add some recommendations. Next one, as you said, there are two levels of recommendations. One, those that propose a screening plan, and the other in which there is awareness only. So you can decide if you wanted to print the next one, the awareness only or not. So the system will show to the healthcare provider what are all the awareness only recommendations that should be made during the discussion and they share the program with the survivor, and then it will be up to let's say share the decision if to have everything printed or only the recommendations which refer to screening plans to be done. Next one. So the overall structure of the passport, the printed version, you have a general recommendation for follow-up, which is the introduction. Next one, then you have general recommendation, which mostly cover the awareness only recommendations. That was a little bit tricky, but we believe that indeed they address almost all the awareness only. And then you have the survivor specific recommendations, that is a printed version. Next one, in which the printed version, they say you might be at risk, in this case, of fertility or thyroid dysfunction. Next one, because you were treated with and the system will automatically print, for example, this patient received alkylating agents, not, let's say, pelvic radiotherapy. So that what is going to be printed is exactly the factors that activated that algorithm in that specific survivor. So it's very survivor specific. Next one. And so then there is a text of the recommendation. So this is a final printout. Next one. So this is the overall plan in which you have the general awareness, survivor specific, and at the very end you have the plan for the next visit. So let's say for in 2021, here they say you will be seen at the Hospital San Martino or at our center to do cardiac evaluations. So there is the plan for the next visits. Next one. So thanks to previous work in the previous European project, now in PanCare SurPass and PanCare Followup, these are the countries which have already complete set of translations available for the passport, both for treatment summary and for recommendations. These countries are those which at certain levels they are already using the passport. The real implementation is not only in Italy, but Lithuania and Croatia are starting, and the other countries, thanks to the PanCare SurPass project, which will be presented by Desiree tomorrow, will start this year. And also Israel, just for information, has asked to be, we are just working with them for the translations, and they will be using the passport. Next one. So the follow-up form, very, very quick. Next one. So the idea is to have a form which pop-ups, next one, with a summary of the previous follow-up visit. And then you have next one, you say, you put the data of the visit, you will make a update of medical history. There is a summary of physical exam, imaging test, and what are the prescriptions. The final summary will be ready for the next follow-up. This is good for the survivor to have this information. We have a space for to have a summary of the chronic conditions, and we will see later on. And there is also space, the next one, to have a communication from the survivors between two visits in order to have update information if something happened between the last visit and the next one. Next one. And that is only for research purposes. We are drafting an academic proposal for coding the chronic conditions. So this is a more complex system. It's a 6-tier system, but as I will show you, it is not as complex as it looks like. So there are 6 systems which define the cardiovascular central nervous system, for example. Next one. And so you have the system, then you can define within the system which is the organ which is affected. In the third level, you define it, in this case here, if there is hearing loss or it's tinnitus, and then you can go more in detail giving the grading of the system. Then tier 5 is the exact data, and tier 6 defines the raw data which might be used. Next one. So this there is the passport comes with the user guide. The next one. And the structure is you can have either remote data entry, next one, or automatic information from your medical system. Everything goes to the survivors in a secure way, next one. And survivors can share with their oncologist, the next one. And or in the future, they will be able to update with cancer patients reported outcomes, next one. Oncologist will eventually be able to update the passport, the next one, and the same, the information will go to the national institutions. Next one, we have generated the ability to access the passport through a QR code. Next one, will be very quickly, so that describes the process, how to generate the QR code. Next one, and what are the process that the survivor will need to do to generate his own personal password, generate the QR code, and then access the QR code with either his own password and a numeric ID. So this is already setting up only in Italy. Next one. And because of that, then the survivor can either generate his own passport in his own language, or choose another language in case he moves to another country, and to have it automatically translated in the new language. Next one. So the passport is now on the Sineca dataset in Italy, but can also be implemented locally in different countries. Next one, what we are thinking now is to make it to put in an open source level in the European cloud, which has been announced by European Commission. Next one. Okay, skip this one. So there is this user guide, as already mentioned, next one. And this is a website which is still under construction, but you can access to the passport, survivorship.passport.org to have more information. I think I'm done, thanks you. And I apologize for having broken the time which was given to me.
All good, Riccardo. Thank you very much. Both presentations are now open for questions.
We were very clear.
I think so. Mary, please.
Hi, Riccardo. Thank you very much. It was extremely interesting, the presentation of the passport. Just how it will all work. For example, you know, most children will be under several different professionals, the radiation oncologist, the main oncologist, the surgeon. Does every one of those tap into the passport and put in their data? How would it work?
The way it works here in Italy, if a patient, if a survivor was treated in different hospitals, in different, what we need is to collect the information either from the survivor himself that comes to our hospital with all the full documentation. Otherwise, we contact our colleagues in different hospitals to collect the piece of information we need, because otherwise we will not be able to do that. In cases that the passport allows the data manager to say if the given doses is actually all calculated or is only estimated. So we generate the passport at the best of our understanding and the best of our knowledge, but the passport provides the information and states that the information is 100% accurate or it's the best of our information. So, and that is part of the shared decision making with the survivor. When we decide, we believe that you should have received the radiotherapy, for example, to the chest because you had Hodgkin disease. We do not know the dose, and then we make our best guess of what could be the dose, and then we decide what is the risk stratification. In PanCare SurPass, but I think Desiree will say tomorrow, we are now also developing the so-called intention to treat approach, in which we are collecting all the expected cumulative doses of the previous protocols, starting since at least in our cases, in protocols of the 70s. And because sometimes the documentation has been lost, destroyed, or whatever. And in those cases, we will generate passports with the intention to treat approach. So based on the expected doses of protocols given, let's say, in the 70s, which is better than nothing.
Thank you, Riccardo. Maeve, please.
I thank you. It's just in relation to the guidelines. That's what my question is in relation to. So the radiotherapy, patients who have radiotherapy, a lot of those guidelines are probably based on photons rather than proton beam therapy, which is probably becoming more frequently used for pediatric patients. Would you have to wait for long-term data before you would update the guidelines? You know, to make them more reference to protons rather than photons? Or is this something that you could possibly extrapolate from, you know, the doses that protons produce versus photons? Like it's probably quite tricky. I'm just wondering how would you go about that and what would be the time frame? Thank you.
Will I answer that? I mean, I think you're absolutely right. It's going to be quite tricky in the absence of definitive information. And I think the question of whether you can extrapolate from photon treatment late outcomes in terms of late effects to proton treatment is still under very active discussion, as I'm sure you'll be aware. So I guess really we have to wait for greater clarity in answering that before we can really make an impact on any changes in guidelines. I think we need to remember that, obviously the purpose of the IGHT guidelines is very much to produce evidence-based recommendations. And yes, we can and have produced consensus-based ones, but I'm not sure there's a consensus about the answer to your question yet amongst radiotherapists and oncologists. So we need more clarity on that, I think. I'm sure in a few years' time, we might be able to answer that a little bit differently, but I'm not sure that we can in 2022.
This goes back to what the slide I've shown on a dosimetry, organ dosimetry based on a radiotherapy plan. The information, as Leontina wrote, that is clearly expressed, are based on relevant manuscripts published in journals. And of course, the manuscripts, as we know, of course, the information of very late effects are based on treatment given 20 or 30 years ago, because they are the first in the world. So we unfortunately, I think we will need several years to have information on proton therapy and also on three-dimensional radiotherapy. So now we can collect the exact dosimetry of the radiotherapy received by the thyroid gland in a leukemic irradiated patient. Now we say that if you get the irradiation to the area involving the thyroid, you might be at risk of. So this is a very, I mean, I think in 20, 30 years, our nephews will say, look what they will be doing in the 2020, because it is very, very basic. At least I think the more sophisticated will be the radiotherapy plans, I think we will get more detailed information of the effect radiotherapy dose to the organ. Now we are talking about
I think, Riccardo, I'm not that pessimistic, because I think we can already translate the evidence from protons to photons. So because we have also a lot of studies who have dosimetry at the organs from all data, so we don't have to do everything again. So I'm really discussing this in our hospital with the radiation therapist, because everyone is thinking, oh, these are all data. No, we have already a lot of data that we can extrapolate, and we should take really care for that.
Yeah, the experience in PanCare SurPass from Florent de Vater, as you know, so they're extracting the dosimetry on old patients. It is not easy.
Yeah, so, but we have evidence for cardiac, we have evidence for breast cancer, we have a lot of evidence for colon cancer already. So let we look to the evidence that's there, because we should not do everything again. And the most important thing is proton therapy will be.
Absolutely, I agree that is a very important first step in any case.
I mean, I think you're right, Leontin, but I think there is also still debate in radiobiology and amongst radiotherapy, particularly I think in the neuro-oncology field. And I think we will need a bit more maturity, at least over the next 5-10 years, that the people who were treated 5-10 years ago in the early days of proton treatment, we can see what has happened to their neuroendocrine status and so on. Yes, dosimetry should tell us a little of that, but I think the story is a little bit more complicated than that as well.
And Lorna, do you want to say something as a radiation oncologist?
Yes, of course. I agree with you, Leontin. We have many data coming out from PanCare SurPass studies as well, actually, for example, for bone sarcomas. We have new evidence that even small doses are very important, causing bone sarcomas, actually. So, and for example, spleen 10 grays is enough to cause asplenia from the latest article. So I agree that we have a lot of evidence, and we use these evidences nowadays in planning radiotherapy treatment. because now we have a possibility to contour every organ at risk. So we now we contour spleen, and we try to avoid the dose more than 10 grays, for example, from this evidence we have now. And the same is, for example, for bones. We can try to avoid to give such a dose, for example, more than 5 grays sometimes. So yes, it's very important. This evidence we use in everyday practice now in treatment of, in planning of radiotherapy treatment in children, and of course in adults as well. So yes.
I agree with Laura. I am a radiotherapy oncologist too. But yes, we can avoid some organs now. But for example, if we have 10 grays on 5% of the breast, we don't know if afterwards we need a breast screening, because data are quite old. And so we know that above 10 grays, we have to do a breast screening. But we don't know if it's 10 grays on all the breast, or if 10 grays on 5% of the breast is still significant. So
Charlotte, that are new data that we will need. So, and I think we now have an international pooling data set already, where France is also putting data in, and the whole world. So we will get information on that. And if the risk is really low, then we don't need screening. But we can.
I want to say that it is not so evident to translate all data in new recommendation. We have to pursue the research.
Yeah, and I think this is just to comment. I think this is one of the most important things to say here. That as we discussed the living guidelines, the survivorship passport, you saw that you have always this drop-down menus will develop. So we have version number 1.2, and we are just in PanCare SurPass producing version 2.0, and of course there will be a 2.1, a 2.2, etc. And I hope that this community will, of course, give the input for this version numbers.
Thank you. Menya, please.
Yes, thank you. I'm just wondering if the survivorship passport can work in countries that there are no digital medical files, that our kids are treated abroad, or they are doing surgery abroad and return back to Greece, for example, for continuing the treatment, and there aren't any follow-up centers or any pediatric centers outside Athens, for example. How can a survivorship passport work in these countries? For example, in Greece, retinoblastoma is not treated in our country. The majority of kids are going to Italy for treatment, and then return to Greece for follow-up care that there isn't any follow-up care, as you can understand. So how can the survivorship passport work in these countries?
The passport, as I said, when I was using the CCI slide, there was differences across country and even between countries. So the passport, the version I presented today is not electronic. So what we are doing here in Gaslini, we are collecting the information and storing the information from medical records on paper. So whatever is the documentation, as I said before, we collect the information and we put it manually into the passport platform, okay? And then we generate a sort of treatment summary, which could be very accurate or less accurate, but there is a space in which you can say this is accurate or not accurate. Of course, you need to have an healthcare provider who will help the survivor in making the plan, because if you are in the middle of the forest and you don't have access to any medical organization which will do the mammography in case you need, or the echocardiogram, that is a problem. And that is why Europe is considering to have a sort of cross-border transfer of data. Usually the patient shouldn't travel, but should travel the information. So if in Greece you do not have anything, that is a problem. which should be addressed in international health system. The passport can, as we say, empower the survivors. So based on the minimum information I got here, so without going into the details of how much radiotherapy received my breast gland, I know that I received the radiotherapy to the thorax, so I know that I am risk of breast cancer screening. And then you needed to have a sort of alliance with some of healthcare providers who has a vision, who can take care of the care in your country. So I think there are different levels of the quality of the information you can put into the passport. The passport states clearly for each treatment if it is exactly given or is estimated. So you may have not the maximum, but a reasonable good care plan, which then, of course, the strategy is up to the survivors community to push with their health system in order to have accurate long-term, not accurate and specific long-term follow-up clinics.
Thank you, Riccardo. Giuseppina, please. We can't hear you.
No.
You can write maybe your question in the chat. Any other questions or comments?
I would have a slight addition or comment to what Minja just said. So what Riccardo, of course, is presenting with the survivorship passport is somehow ideal world, but we are under current discussion to display different scenarios we have across Europe and of course across the world, leading as well to the situation that you do not have a healthcare practitioner and no data is available, or that the survivor him or herself can complete the survivorship passport maybe with a kind of validation function after by somebody experienced in late effects and treatment summary. So this is future work, and we hopefully all can take our part in that, because I think it's essential that not only those who have the complete diagnosis and treatment summary will receive the passport, but as well those who have minimal data at hand and can enrich them by intention to treat approach or other modalities.
Thank you, Desiree. So Riccardo, now the question is in. I would like to know, how long do you follow up patients in your centers?
Yeah, that is a very good question. So that I can say what is the situation in my center and what is the situation in different. Even in Italy, it is different. In some countries, in my country, some centers allow follow-up from the pediatric oncologist only up until age 18. My institution does allow us to have follow-up in theory forever. The point is that we are a pediatric institution, so it is difficult for our consultants to make a consultation to a 40-year-old survivor. So now we have signed an agreement with the general hospital in our city. So we are setting up a sort of transition clinic with the general hospital in our clinic, which is a shared meeting with our pediatric oncologist, our late effects expert, and a consultant from there. And I know from Lars in Sweden is almost the same. They having a meeting, they having a follow-up clinic in Malmo, in which there is an adult hospital in which they coordinate this. Again, this is the transition is something for the future to be developed. In the Netherlands, they are very lucky, so they were able to set up a central center for all the survivors from the Netherlands, but they have a very several good points, which are the size of the country, the wellness of the country, and the organization of the system. In countries like Germany, Sweden, Italy, which are so long, it is impossible to have a central central hospital. And so I think as local circumstances will organize how the transition clinic can be organized.
Thank you. So this will also be covered a little bit in the session this afternoon. So maybe one last question, Paula, please.
Thank you so much for all the organisers for today. It's a really fantastic course. And thank you for such an interesting talk on the passport. It's just probably a technical question. Obviously, you know, information and guidelines are being changed year in, year out and being reviewed. So when we have this fantastic online document, will the guidelines or will the recommendations that we give to the patients change automatically on this online system?
No, that will automatically not. So we have the information. If they say the new recommendation will change, like in case of the breast cancer recommendation has been changed, you needed to change the algorithm and the text of the recommendation. As I said, we are considering or making it an open source platform in the European cloud. So there will be a sort of working group which will be as soon as a new recommendation will come up, we will review the algorithms and there will be a statement at which level, at which date there was the last update of the passport platform and recommendations.